Uh, Alright, so again, going back to condition 1, we were at SLE. Before doing SLE, let's just do it very very fast. So osteoarthritis, it is a degenerative disease characterized by articular cartilage deterioration with new bone formation at articular surface. So you'll be having tenderness. You'll be having tenderness at the joint line. Just a second. Okay, where was it? Joint line tenderness. You can hear everything good? Okay. Yeah, you'll be having joint line tenderness crepitations on moving the joint and irregular and enlarged developing joint to formation of peripheral osteophytes. Peripheral osteophytes is an important feature. It is important in very it's important in a lot of subjects. So let's see. Okay, so you have irregular and enlarged joints due to peripheral osteophytes, irregular enlarged joints, and deformity of knees, deformities, effusion in the terminal limitation of joint movements in the terminal level. So X-ray, you can see narrowing of spine joint, subchondral sclerosis, cysts will be there, osteophyte formation will be there, loose bodies will be there, and deformity will be there. So treatment is analgesic protective agents of the chondroitin sulfate, glucosamine and chondroitin sulfate for the cartilage. Vesico supplementation, you give sodium hyaluronate. You have supportive therapy, which is NSAIDs, weight reduction, exercises, heart palpitation, surgically you have osteotomy, joint replacement and debridement. So again going back to this. So systemic systemic lupus erythematosus. It is a multi-system connective tissue disorder. Known etiology is damaged by autoimmune, and it is most common in women of childbearing age. Etiopathogenesis, there is disturbance of immune regulation. It is HLA-B8 and DR3 predilected, and there is environmental factors, it is sunlight, and drugs you have estrogen, androceptive, quinine, isoniazid, hydrolysine, chlorpromazine, and phenytoin, and procainamine, which is most frequently reported. Infections also, it can be due to Epstein-Barr virus. So autoantibody in SLE, you have anti-nuclear antibody, which can be anti-DNA single stranded, double stranded, anti-RNA, anti-SM, anti-Smith proteins. You have anti-LA, SSA, SSB, anti-LARA or SA, SSA, SSB, and anti-UA, which I don't remember. I don't exactly know the remaining, but yeah, anti-cardiolipin is one thing, anti-erythrocyte, anti-platelet, lymphocyte, neuronal, MA, PCNA, I really don't know. There are a lot of auto antibodies, but these are most important. So clinical presentation and one of the four of the following requires a diagnosis for SLE. You have malar rash, which is a butterfly rash flare with exposure to UVB, photosensitive, and you have discoid rash with scalp and face. Photosensitivity will be there. Oral ulcers will be there. Arthritis can be seen. Serositis, which is pleuritis or pericarditis, can be seen. Liebman-Sachs endocarditis is a dangerous complication. Renal involvement will be there. Neurological seizures, psychosis. Hematological, you have leukopenia, thrombocytopenia, and immunological markers. You have double-stranded DNA, anti-Smith, and other anti-nuclear antibody, autonuclear antibodies. And then you have diagnosis. You have anti-nuclear antibody SA, and C3 and C4 level will be decreased. Elevated ESR can be seen. So ELIS also you can see lupus anticoagulants, anticardiolipin antibody. So prolonged PTT not compatible with any addition of plasma. So it is responsible for first trimester recurrent abortions and thrombocytopenia. So treatment in this case is NSAIDs, corticosteroid creams for the skin rash, and hydrochloroquine and oral corticosteroids for skin and arthritic symptoms. You can also give cytotoxic drugs, azathioprine, cyclophosphamide, and mycophenolate for lupus nephritis. Mycophenolate is one important thing. Then you have scleroderma, which is multisystem fibrosis of skin of blood vessels and all. I'm not going to do this. Scleroderma syndrome is chronic multisystem autoimmune disease characterized by lymphocytic infiltration of exocrine gland resulting in xerostomia and dry eyes. You have primary and secondary Zika syndrome, secondary rheumatoid arthritis, primary biliary cirrhosis, and SLE. So dry eyes, dry mouth, parotid enlargement, arthritis, renal phenomenon, vasculitis, lymphoma, and acute renal tubular acidosis. So you can examinations you have Shima's test, which decreased tear production, rose Bengal stain for corneal ulceration, anti-nuclear antibody also you can do, anti-LA, anti-SSV, anti-RI, Rho and La, and measurement of salivary flow, cerebral gland movement can be done by scintigraphy, and biopsy for lymphocytic infiltration can be seen. So treatment you have artificial tears, pilocarpine, which increases the acetylcholine, increases tear and saliva production, and autoimmune cyclophorin, mycophenolate, and mycophenolic acid, and one more thing was methotrexate by mycophenolic acid, methotrexate. Okay, this is a little bit different. Mycophenolic acid. Okay, then osteomalacia is of course it will be. I'll just skip all this. I have a feeling I can do it pretty well. Then finally you have polyarthritis nodosa, which is a necrotizing inflammation of small and medium sized arteries. So you have thrombosis, infection, and autosomal direction along with PAN. Pulmonary arteries are not involved, and mechanism is immunopathogenic. You have immune complexes formation in situ, antibody mediated cell damage will be there. Cytotoxic T cell will be against the components of blood vessels. And you have non-human mechanism, which is infiltration of wall by microbial agents. So clinical features, you have renal, mucoskeletal, you have peripheral and nervous system, you have GIT, skin, cardiac, CNS, and genitourinary. So renal, you have renal failure, hypertension, muscular arthritis can be seen, peripheral neuropathy can be seen, GIT, you have abdominal pain, nausea, vomiting, peripheral cutaneous rashes, all those skin rashes and all. You can inform liver, pancreatic infection, bowel infection, everywhere infection. Infection is one important point. Then you have formation of CNS, you have CVA, seizures, and all of them. My pericarditis, congestive cardiac failure, and testicular ovarian pain. So diagnosis, you will be having elevated ESR, hyperglobulinemia, biopsy of the involved will show medium-sized artery pathological changes will be there, and angiogram for abdominal vessels of GIT and kidneys and all. So treatment, you can give corticosteroids, prednisolone, and immune suppression drugs, cyclophosphamide with 2 mg per day. So next we go on to Pelty syndrome, which is variants of rheumatoid arthritis. It is characterized by pancytopenia, neutropenia, splenomegaly, and lymphadenopathy. Still's disease is another rheumatoid arthritis occurring in children, which is a variant of rheumatoid arthritis. Mono or polyarthritis, fever, micropapular rash, splenomegaly, lymphocytopathy, leukocytosis, and serum negative rheumatoid arthritis, and anti-nuclear antibodies are negative. Then nephrology. Going on to nephrology, you have first of all hematuria. It can be glomerular hematuria, non-glomerular hematuria. There you can see dysmorphic RBC. Mean corpuscular volume will be less than 72 femtoliters, and presence of RBC cast and concomitant proteinuria will be there, which is more than 1 gram per kg per day. Non-glomerular hematuria will be having isomorphic RBC will be there in the in the urine analysis. Mean corpuscular volume is more than 72 femtoliters. There is absence of RBC cast and no significant proteinuria. So it can be of three causes: renal, extrarenal, and systemic. Renal, you have glomerular disease, carcinoma, cystic disease, trauma, venous malformation, emboli. Extrarenal, you have canaliculi, infection, neoplasm, prostatitis, urethritis, and bladder catheterization trauma. Then you have systemic, you have coagulation disorders, anticoagulant therapy, sickle cell anemia, and vasculitis. So you have intermittent hematuria, which is caused by IgA nephropathy, Alport syndrome, tuber, and autosomal dominant polycystic kidney disease. Okay, then you have acute nephritic syndrome or glomerular nephritis, glomerular inflammation leading to immunologically mediated injury to glomeruli. It is primary or secondary. Primary in IgA nephropathy and post gram negative infection. PSGN. Post streptococcal infection, then RPGN. RPGN, I'm not sure. SLA can be then hepatosplenal HSP. Owen-Schoen purpura can be there. MGPN, myeloproliferative glomerulonephritis. So this is what is it? RPGN is retroperitoneal or something. Wait, I'm forgetting. Rapidly progressive glomerulonephritis, something like that. Okay. Goodpasture syndrome, microscopic polyangiitis, vagus granulomatosis, all of them are immunologically mediated injury to the glomeruli. So, pathogenesis, you have deposition of immune complexes in the glomeruli, which triggers complementary activation, fibrin deposition, platelet aggregation, release of cytokines, and free oxygen radicals. So, clinical features, you have hematuria, RBC casts are there, oliguria, hypotension, uremia, proteinuria, and edema. Edema is seen. So investigations, you have urine microscopy, RBC cast, dysmorphic RBCs. Culture, you have throat swab and inflamed skin, antistrepsin lysin. C3 level complement will be reduced, urinary protein can be there, and urea and creatine will be elevated. And renal biopsy, you can see electron microscope, there will be proliferation of glomerular cells and infiltration by leukocytes. You have immunofluorescent microscopy also, which will show immune complex deposition. All of these are autoimmune. So antistreptolysin O, C3 level will be reduced. C3 level will be reduced. Urea and creatine will be increased. Urea protein also will be. You have to do investigation. It may be there, it may not be there, depending on the cause. Throat swab, inflamed skin swab, RBC cast, dysmorphic RBC, all of them can be checked. Management is initially you have to give salt restriction, antihypertensive, antibiotics dialysis. So severe oliguria, if it is there, fluid overload and hyperkalemia is there, you can give a dialysis and remove all the potassium and fluid overload. Finally, you have the main question, which is nephrotic syndrome. Presence of glomerulonephritis sufficient to produce proteinuria, hyperlipidemia, edema, and hypoalbuminemia. So in etiology, you have primary and secondary. Primary, you have minimal change in mesangial glomerulonephritis, focal segmental glomerulosclerosis, and myeloproliferative glomerulonephritis. Secondary, you have diabetes mellitus, amyloidosis. You also have, I believe, you have Hodgkin's lymphoma, leukemia, carcinoma, breast and all, and bacterial endocarditis, syphilis, malaria, gold, penicillinamide, probenecid, captopril, and NSAIDs. All of them will be showing secondary nephrotic syndrome complication. So clinical features, it is insidious in onset, generalized edema, it is fast urine due to presence of protein. Complications, you have venous and pulmonary embolism. Clotting factors also is provided. Loss of immunoglobulins in urine, and compensated hypercholesteremia, and specific loss of specific binding protein, which is thyroid binding globulin, and loss of immunoglobulins in the urine infections you can have due to infections. Compensatory hypercholesterolemia in response to hypoalbuminuria, where then there is atherosclerosis and xerostomia. Okay, so investigations, you have urea blood is more than 3.5 gram per day. Serum albumin, serum burn creatine, and biopsy can be done. So treatment, you have bed rest. GFR more than 60 is no dietary protein restriction is required. If GFR is less than 60, dietary protein restriction of 0.8 gram per kg per day. You have diuretics, they relieve edema but do not treat the underlying disorder. You have salt-free albumin infusion, treatment of underlying cause of precipitating factors. Proteinuria is controlled by ACE inhibitors and anticoagulation. You have deep vein thrombosis, arterial thrombosis, and pulmonary edema. The polycystic kidney disease you have, and they have two modes of inheritance: autosomal recessive and autosomal dominant. Then in recessive, it is mutation in PKD1 on chromosome 6. In dominant is PKD1 in chromosome 16 and PKD2 in chromosome 4. This is more common. They have flank pain, acute loin pain, nocturia, hematuria, urinary infection, uremia. It is associated with hepatic cyst and intracranial aneurysm, berry-aneurysm, and hepatic aneurysm, hepatic cysts. So complications, you have UTI, hypertension, renal calculi. Diagnosis is by CT, liver ultrasound, and head CT for the aneurysms. Treatment, you manage with UTI and all whatever calculi and hypertension. You complications you treat. So you give dialysis if functional renal declines, and nephrectomy for intractable pain. You remove the kidney if the pain doesn't go, and dialysis if the renal function declines. Then you have acute kidney injury or acute renal failure, which is a syndrome characterized by rapid fall in GFR, in retention of nitrogenous waste and electrolyte, and acid-base disturbances. So you have RIFLE criteria wherein risk, injury, failure, loss, and end-stage renal disease will be there. GFR is reduced more than 25%, more than 50%, more than 75%, more than persistent AKI for more than 4 weeks, and more than 3 months will be end-stage renal disease. All of this you have to redo. This is not correct. EKD also I'll redo. I'll just make note of this. Well, I'm at it. Give me a second. I'll just write out a few more things. Hypertensive, emergency, hypertensive and emergency you have to check out, and infections. You have dengue, malaria, and rabies, helmet. All those things you have to check out once, and after infections, CNS. Yeah, AKD and CKD I'll do it with another textbook. Remaining all I'll do of here only. Okay, so hemodialysis is fluid and substances of blood exchange via concentration gradient against a semi-permeable membrane, indicated in renal failure, toxins, drugs, and chronic renal failure, waiting transplantation, and low life quality has decreased. So access can be subcutaneous or shunt, prosthetic filariasis, subcutaneous subclavian, femoral catheters. Complications due to access, infection, thrombosis, vascular complication, high output. Due to dialysis procedure, hemolysis, cardiac hypoventilation, embolism. Because of dialysis procedure, long-term complication, anemia by blood loss, anemia of chronic disease, pericarditis, diverticulitis, hepatitis, non-A, non-B, and aluminum intoxication due to dialysis, dementia due to leading to dyspraxia and seizures. Give me a second. Okay, so coming back, we have renal replacement therapy. So renal replacement therapy is dialysis, hemodialysis, peritoneal dialysis. Small molecules and toxin using diffusion across the membrane. Ultrafiltration is removal across fluid removal across semi-permeable membrane under pressure, and hemofiltration is continuous removal of large amount of solutes with current electrolyte solutions reinfusion. With electrolyte solution reinfusion, then hemodilation is combination of hemodialysis and hemofiltration and continuous renal replacement therapy, which is machine will be there. You just plug it in and it will keep on changing. Urinary tract infection, you have upper urinary tract infection involving the kidneys, and it can be lower urinary tract infection, bladder, prostate, and urethra. So bacteriuria is presence of bacteria in urine significant is more than 10 power 5 in midstream urine, colony forming units of bacteria per milliliter. 10 power 5 colony forming unit of bacteria per milliliter of midstream urea. So pyelonephritis is inflammation in the renal parenchyma. Acute bacterial pyelonephritis is clinical syndrome characterized by chills and fever, flank pain, and constitutional symptoms caused by bacterial invasion of the kidney. So chronic pyelonephritis is renal disease that is caused by a variety of disorders like chronic obstructive uropathy and vesicoureteral reflux. Then you have renal medullary disease, drugs and toxins, and chronic bacteria. So cystitis is confined to the urinary bladder, is cystitis. Urethritis is urethra. Prostatitis is prostate. Relapse is due to microorganism that is usually drug resistant. Reinfection is recurrent infection due to different microorganism. Then asymptomatic bacteria is presence of bacteria in absence of symptoms, and uncomplicated urinary tract infection is cytourethritis following bacterial colonization of urethra and bladder mucosa. Sequel are very rare, and complicated urinary tract infection is infections involving the parenchyma. Pyelonephritis and prostatitis, and infections may be refractory to treatment. Occasionally, it is sepsis, metastatic abscess, and acute renal failure can occur. So, risk factors: you have obstruction to urine flow, congenital anomalies, renal calculi, ureteral obstruction also, ureteral occlusion. Then you have vesicoureteral reflux if there is residual urine in bladder due to neurogenic bladder or urethral stricture or prostatic hypertrophy. There is instrumentation of urinary tract like catheterization, urethral dilatation and cystoscope, and common microbial pathogenesis is E. coli, Klebsiella, Enterobacter. Okay, Staphylococcus aureus and this also will be symptoms will be frequency, dysuria, hematuria, incontinence, retention of urine, fever with chills, and pain over the loin. The investigations, you have urine specimens for culture and sensitivity and colony forming units count. Localization of infection with segmental culture in lower urinary tract infection in male. So first in ml is voided urine is urethral infection, midstream is bladder infection. Then you have prostatic massage also you can do, where you will get prostatic infection. Then gram positive, gram staining, and microscopic visualization. And finally, you have radiography, VOR, renal calculi, obstructing mass. All of them can be done. Treatment is uncomplicated. You can give oral therapy, trimethoprim, sulfametazole. Damn it, there's still so much left. Okay, so I just got my dinner. I'll stop right here and then continue after a bit.